Peter, you want to unmute and introduce yourself and say hello?
Hi, everyone. My name is Peter Swain. I'm a new fourth year from the Lake Erie College of Osteopathic Medicine. I haven't been on CP solvers in a while, just because with my rotations, the timing never overlapped with being able to actually log on and talk. So last time I was on, this was probably June of last year. Since then, I've gotten married. We have 2 dogs. I've decided I'll be applying to both ophthalmology and pediatrics for the upcoming cycle. And yeah, I'm excited to be back on and start off with discussing the case.
Congrats on all those great events and decisions, Peter. Thanks, and great to have you here. Thank you for volunteering. So who wants to buddy up with Peter? Let's give it another couple of minutes. Travis, almost everyone on the call probably knows you, but maybe not everyone, especially since we have at least one new person listening in. You want to say hello to?
Yeah, hey guys, my name's Travis Smith. I am a CP Solvers enthusiast and team member. I'm a emergency medicine physician in Jacksonville, and I'm an associate dean for LECOM, and I get to see and chat with Peter. He helps me out a lot on our, we have a little morning report that we send out to all the students that have fun little tutorials and CP Solvers materials and facts, and so Peter's a go-getter and is an awesome guy. I'm glad to see him back and happy to see all the new faces on here.
Thanks, Travis. Good to see you. All right, Kevin, thank you for volunteering. Why don't you introduce yourself and we'll have Travis take it away.
All right, my name's Kevin. I've discussed, I think, once or twice before on CP solvers. I'm also a newly minted fourth year medical student at LECOM in Bradenton, Florida. So LECOM seems to be representing well today. Yeah, that's pretty much it.
LECOM represents well every day. It's awesome. We're really excited to have you guys.
Well, you guys ready to go? And I'll start off with the case.
Good.
All right. So first bit, we have a 36-year-old male who presents with a fever after recent travel. He just returned from the United Arab Emirates in July. So that's the first bit, first chunk.
Zavin, do you and Peter want to tackle the first part, and then Kevin and I can team up subsequently?
Let's do it. Peter, why don't you share some early thoughts, your approach, while I Google CDC travel stuff.
All right, that sounds good. A fever and a returning traveler from the UAE is maybe not the case I wanted to first dive into, but nonetheless, here we are. You know, I mean, obviously, first thing I'm thinking of is infection, and also with this being in July of, I assume, last year. COVID is one of the first things in my mind, along with other infectious causes. I think a lot of it will be kind of whittled down based on a review of systems and what other complaints this gentleman has. Other than infectious causes, I mean, fever could also be from a general inflammatory syndrome. So if this gentleman has, I mean, just about anything. I mean, fever for me is actually one of the toughest things to just kind of start off with, which I hope is kind of similar for a lot of people, because it can be caused by a lot of different things. So I think other than that, his age is, I guess, something to consider as well. Just thinking about what kind of risk factors this individual has based on his lifestyle, being a younger person. There tends to be some other like more uncommon things to consider. I mean, you know, drug use is something obviously isn't restricted by age, but it's something that can cause a fever. And I think I just need not a lot more information, but a couple more things to really kind of whittle down between the scheme. I can't really go much further than just that first bifurcation.
I think that was great, Peter. So you mentioned you're already thinking both infectious, which for acute fever is most common, and non-infectious causes off the bat. I think that's always a good approach. I think it's good to both think about the immediate risk factor we heard about, which is recent travel and potentially exposure to pathogens that are present in that part of the world and not others, but also to realize that travel doesn't protect you from, cholecystitis, right? And so I think there's a few kind of specific travel associated infections that often come to mind with travel to the Middle East. And some of them can actually present with non-localizing fever, just sort of systemic illness, things like typhoid, things like some of the viral infections like yellow fever, things like brucellosis. But it will certainly be very helpful, as you say, to just get more of a history of like, okay, what's the story? You're having fever, what else, right? So I'm sure it'll be a fascinating case, like Travis's always are. So we can get more information with this good intro and go from there.
All right, second aliquot. So he returned in July when he developed fever, sweating, a headache while he was on the plane. Over the next 4 days, he had a persistent fever of 102 to 104, no rhinorrhea, no sore throat. He noted having a smoker's cough that had been unchanged. Upon arrival, he went to an urgent care on day 4 and had a normal x-ray. But of course, just like everywhere you go, he got azithromycin. And that didn't help so much. Upon further questioning, he denied diarrhea, nausea, or vomiting. He denied any urinary symptoms. He denied any joint pains, and he denied rash. On day 8 of his illness, he still had persistent fevers and presented to the hospital. And at that time, he had a temp of 102.4. I'll give you a little bit of medical history for this aliquot as well. And so he has morbid obesity. His BMI is 48. No other medical problems that he knows of. He currently has only been taking acetaminophen and ibuprofen for his fever. Social history. He lives some of the year in Northern California and some of the year in the UAE. He lives with his wife and 4 kids. He's a current smoker and denies any alcohol or drug use. Some other history for him. This is for Kushal. He had some exposure to camel meat and milk 4 weeks ago. And he was around sheep and goats about 2 or 3 months ago. And that's because in the area he has livestock, but he doesn't think he had any direct contact. So I'll leave that for the second aliquot.
Thanks, Travis. I don't know how many VMRs have included a camel as a guest star, but here we are. We'll see if it fits into our thinking at all. Kevin, do you want to share your thoughts?
Sure. One of the things that I'm sure Travis left this out on purpose is I'd kind of like to know a little bit more about the fevers. Are they just kind of constant, persistent? Are they cyclic? And if they're cyclic, how many days in between the fevers spiking, what the time course of it is. I also think it's important, now that we know he lives in Northern California, to not exclude, endemic fungus to the area. Just because he's a returning traveler doesn't mean that this is where he picked up the infection. It's quite possible. So we still need to keep, the exotic, so to speak, pathogens in mind. But I think it's also important to keep kind of the more terrestrial, I guess, if you want to put it that way, pathogens in mind, just because, he's moving back and forth between the two. Right now, it's very hard to kind of narrow down the differential. He's had so many exposures, and he's been subject to, the potential for so many pathogens that, at this point, it really seems like that might be the cause. The smoking is interesting. I'm sure Travis, as an astute physician, got a PAG year history. So I'd like to know a little bit more about that to kind of determine, his risk factors for other things like asthma, or, if he's possibly got some type of autoimmune condition that we're not aware of yet. And I think, it's important just to kind of keep in mind his risk factors, his obesity, his smoking, because those are all things that are going to play really into the pathogenesis of whatever is actually going on. So right now, just really hard to kind of get a grip on things. Infection, seems to be at the top of the differential right now, but it's a very fluid thing at this point.
Beautiful, Kevin. Thank you for anchoring us to less exotic kind of locales and differential diagnoses by reminding us very common things could be happening here, things that happened to him in Northern California, not in the United Arab Emirates. So I think that just open-mindedness, not to get too narrow and focused on the exposure history and what interesting diagnoses that might give us is really, really critical. I'm with everyone so far that given the acute onset of this fever and the lack of known kind of major comorbid conditions other than the tobacco use and the obesity makes infection very likely. And now that we've got a little bit of exposure history, I do wonder if we can start sort of fleshing out as we discuss within the infection organism categories. I think it's always helpful to be very systematic about thinking about bacterial, viral, mycobacterial, fungal, parasitic. And what's tricky is in that bacterial category, of course, thinking of the common things. For example, a 36-year-old man who smokes could get pneumonia, right? And a routine community-acquired bacterial pneumonia we would hate to miss. Hopefully that normal chest x-ray he got at urgent care was perhaps reassuring, although we've discussed on this morning report before, there's even diagnostic limitations in plain chest x-ray for picking up a pneumonia. So I think that's still on the list. So in the common bacterial category, we remember the usual stuff, but then also thinking about zoonotic infections, because we do have animal exposures here, as well as kind of rickettsial diseases. We didn't hear of any kind of tick or arthropod exposure, but I just mentioned that because the bacterial category is really pretty big, and I always think of rickettsial, zoonotic, in addition to community-acquired normal bacterial organisms as their own categories. I think the fever and the returning traveler history, I like that Travis is giving a shout out to Kushal, who's always great at thinking about particular risk factors, aligning to specific infections. Clinical problem solvers, I believe, is a fantastic schema for returning traveler fever. And within sort of exposures, there's all these other factors to think about, right? How long was the trip itself? We hear this gentleman's in UAE for months at a time. So certainly long enough to give it exposures in a lot of different ways. Well, what types of locales, urban versus rural? Were there any sort of side trips? Were there any kind of just exposures to people who could have transmitted infections? Certainly we're in a global pandemic now, so not putting it all on the animals, of course. So all of that is incredibly particularly rich history. His syndrome seems to be fevers only at this point, and I totally agree with Peter. That makes it kind of tough and non-specific, but I think with really focusing on the infectious category for now, keeping in mind some of the autoinflammatory category later on as things evolve is the right way to go. And I think specifically thinking about a very sort of common differential for this gentleman, right? Does he have a pneumonia that wasn't picked up on x-ray? With a thorough review of systems, are we sure that there's not some sort of GU infection, sexually transmitted infection? Then we can really start fleshing out specifically those other categories. And I think with some of his livestock exposures, we can start thinking about, okay, what do we test on physical exam and diagnostics for brucellosis? I certainly hope anthrax kind of was an exposure with animals, but we're actually starting to open up some of these Coxiella with Q fever, if he had any rodent kind of urine exposure, leptospirosis. So we actually can start working out that zoonotic infection category as long as we follow Kevin's advice, not miss the common stuff going forward. So maybe I'll stop there. We can get more exam and more info and kind of build on that with the rest of the case.
You got it. You guys are onto something. So let's start with some vital signs. So his temperature was 99.6 or 37.6 Celsius. Heart rate was 87. Blood pressure was 113 over 63. Respirations 16. O2 sat on room air was 93%. On general exam, he appeared uncomfortable. He was diaphoretic. HENT, there was no conjunctival icterus, or sorry, no conjunctival icterus. I almost said scleral icterus. No tonsillar exudates, no pharyngeal erythema. Neck exam, cardiopulmonary exam, and cardiac exam were all normal. Abdominal exam revealed no hepatomegaly or abdominal pain, but there was splenomegaly present. Neurological exam was normal. And his skin exam was unremarkable, no rashes. I'm going to go ahead and also give some initial labs that you guys can discuss as well. So his white blood cell count was 8.8. The differential was 39% PMNs, 6% bands, and 22% lymphocytes. Of those, there were 29% atypical lymphocytes, 4% monocytes. His hemoglobin was 13.4, which the lower limit of normal was 13.5. His platelets were 146,000, and the lower limit of normal was 150. Chemistry panel, sodium was 132, potassium was 3.4, chloride was 97, bicarb 28, BUN was 11, creatinine was 0.8, glucose was 167, liver function studies, his AST was 267. I'm sorry, ALT was 267. AST was 137. Alk Phos was 106. His total bili was 1.8, which was abnormal. The lab on here is less than 1.4 is normal. Albumin was 2.8, which is low. Normal low on this lab was 3.5. Total protein was 7. Ferritin was 1900. CRP was 8.9. SED rate was 17. And first set of blood cultures times 2 were negative. And I'll just give a repeat chest x-ray was normal, no infiltrates. And a CT abdomen pelvis showed normal gallbladder, diffuse fatty infiltration of the liver, and an enlarged spleen measuring 17.6 centimeters. And that is the end.
Wow, that's some aliquot. A lot of helpful information. Peter, why don't we kind of just have a conversation back and forth, just because there's so much data. So first, what do you think about the vitals and exam? Anything stand out to you?
You know, his fever's come down since he first came into the ER. So, I mean, it's in flux. That's something I was wondering about, is how often or like how constant is his fever, since it's been 8 days now. So it is a little bit in flux. I mean, he came in and it was 102, close to 102, I think. So it's already dropped several degrees since he first came in, which is good. I mean, that doesn't tell me much, but at least he's not holding a steady fever for extended periods of time. On exam, I think anytime splenomegaly comes up, it's something that is important to take note of. I mean, it can mean a lot of different things. Usually I would break it down into either something with congestion in the spleen or it's sequestering something. I don't really know off the top which one it is, but that's kind of how I first start breaking down splenomegaly. And then since it's not combined with hepatomegaly, I think that's also important to take note of. It's solely the spleen, so it makes me, I guess, lean a little more towards sequestration. And then the atypical lymphocytes and the lymphocytosis in general, without having an overall leukocytosis. You know, I'm not really sure what to make of that, because I was expecting him to have a leukocytosis. I was expecting a lot higher white blood cell count, but that's something that I'm kind of still working through in my head. So I did kind of spill into the labs there, but.
Good stuff. Yeah, the white count, you know, the total white count, I think is, it is what it is, but you know, the different types of cells that comprise the total white count are really kind of stimulated and regulated by somewhat different mechanisms. So the differential I always find extremely helpful, right? So in this case, you're right, there's not an elevated absolute number of neutrophils, but because the neutrophils can either go up or go down in sepsis and severe systemic inflammation, that doesn't necessarily mean that there's not, you know, something real going on or something serious going on. What's more helpful to me is the presence, the abnormally elevated presence of different types of cells, which is these lymphocytes and atypical lymphocytes, which, by the way, Travis, the current number of cells that we have add up more or less to 100%. So I'm guessing that there was 22% lymphocytes and an additional 29% atypical lymphocytes, unless there's also a bunch of EOs, which we can assume there's not. Is that correct, Travis?
Yeah, I don't have any UOs on here. Did I say monocytes? Yeah. Yeah, no eosinophils.
So there's a lymphocytosis and an atypical lymphocytosis, and that really stands out to me. Is there anything that you associate with atypical lymphocytes? What does that mean at all, Peter?
I mean, the first thing in my mind is it just escaped me. Mononucleosis. I think, you know, that's just a very typical association. I know there are many other things that I'm not as well versed in to kind of list off. I've seen a lot of things popping up in the chat, just lots of different diseases that were kind of already on the list with our recent UAE travel. So I don't know if it necessarily helps limit the differential, because now I'm considering viruses much more so, just in general with the lymphocytosis, but also the atypical lymphocytosis usually makes me think about more not commonly seen infections, especially in my area in Pittsburgh. It's just not something you typically see unless it's mononucleosis. So I think it's going to push my differential a little bit wider into diseases I'm not usually considering.
Very good. Yeah, so, you know, and mononucleosis, by the way, is actually a common cause of fever in a returning traveler. You're just exposed to more people, exposed to different, you know, sort of strains and other things that you're not used to. So EBV, CMV are definitely kind of go up on the list. Acute HIV, you know, I think is higher on the differential because of this. It's another cause of kind of a mono-like illness. And in some people, you know, travel is associated with also new sexual exposures that we may or may not know about yet. The other kind of acute mono-like illness that can cause atypical lymphocytosis is is toxoplasmosis. I've actually never, I always hear and read about this. I've never seen a case of such a presentation of toxo, but I do know it's possible. And then the other bacterial infection that I associate with atypical lymphocytosis is Bordetella and Bartonella species. But I'd have to kind of do some in the moment kind of learning to think more about exposures and kind of clinical syndromes and whether it could be a fit here. And speaking of, by the way, I think we haven't really talked about this for a while, but I think this is such a good case to demonstrate the importance of sort of iterative data gathering and hypothesis driven sort of practice-based learning, where when you don't necessarily see a febrile patient who just came back from UAE every day, right? So the semi joke I made early on was that part of how you would take care of a patient like this is immediately, right, kind of look up what infections are more endemic in that part of the world, generate your list of possibilities, potentially review the syndromes associated and the exposures associated with those diagnoses, and then gather history with that in mind, right? To specifically, you don't ask about camels for every patient, but you ask about camels for every patient coming back from UAE with a fever, from the Middle East with a fever, right? So I just want to kind of make that explicit that none of us can or should expect ourselves to kind of have all of this knowledge off the top of our heads. And that you're always taking better care of patients when you have this kind of system of iterative looking stuff up, gathering more information, testing, and so forth. Okay, and I'll just kind of go back to the atypical lymphocytes and say that there may be other, again, less common intracellular kind of zoonotic associated bacterial infections that I wouldn't be surprised to also cause atypical lymphocytosis. But for example, the leptospirosis and the brucellosis and the malaria that we think about for a patient like this, I don't typically associate with that finding. Let's move on. And I want to hear, Peter, what you think about the liver enzymes, as well as I'll point out the difference between the total protein and the albumin, which is 4.2, that elevated globulin, what you make of those findings, if they trigger any kind of considerations.
So I think what really caught my eye through the labs was the liver functions. I mean, the transaminases are elevated, and then also having the elevated bilirubin are all things that kind of help me get a better idea of where infection might be occurring. So my kind of spike to the top of my list is a liver infection of some kind, whether it's hepatitis or like a yellow fever. Since we were talking about specific UAB infections, that's one that's there. I didn't really think many of the other ones that I kind of read through quickly on that list for that area would really spike liver enzymes. But and then the protein gap is something that I'm still kind of getting used to interpreting, but it is something I did take note of. I mean, usually that means that what it's telling me is that there's some kind of immune globulin that's being produced rapidly, or somehow creating that space between the albumin and the total protein. So the next question I would have would be, is it polyclonal or monoclonal? Because if it's monoclonal, that's going to lead me more towards it being some kind of like a liquid tumor of some sort. I mean, I'm not sure, I couldn't really list off the whole gambit. But then if it's polyclonal, that kind of leads me more towards the general inflammatory syndromes or infectious syndromes. So that would be kind of how I break that part of it down. The ferritin is something I think is interesting, although I'm not sure how to break that down. I know it's somehow relating it back to the liver for me, but I'm not sure how to fully incorporate it yet.
That was beautiful, Peter. So I love your kind of that dichotomy to the elevated globulin is really critical pretty much in every case of that finding of is it monoclonal or polyclonal. Going all the way back to the first thing you said is like fever isn't all infection, right? And by the way, atypical lymphocytes isn't all infection either. I've actually seen CLL cells as well as hairy cell leukemia be read on automatic differential as atypical lymphocytes. Those are things that could present with splenomegaly, with fever and most everything else. So even though it's less likely in the patient with this kind of background and context, it's one of the several reasons actually at this point to also look at a peripheral smear to better understand what those atypical cells are, as well as for some of our infectious differentials, including the malaria, including, I don't know if leishmaniasis was mentioned out loud. I think I saw it pop up in the chat at some point, but it's definitely endemic in this part of the world and could present with all of these findings. So some of these pathogens you can actually see a lot of times either as intracellular inclusions or as extracellular sort of presence on the peripheral smear. The liver tests, the liver injury, as well as the ferritin themselves, to me, aren't super discriminatory, I think, in this case. I think most of the things on the differential could affect the liver and, again, just cause inflammation with the ferritin. But going back to the globulin gap, if it is a polyclonal and infectious etiology of this globulin gap, for reasons that I've never understood, acute infections don't tend to lead to acute bacterial infections don't tend to lead to a lot of polyclonal gamma globulin production. It's often either more chronic infections, chronic inflammation, or certain viral infections, and specifically hepatitis viruses, HIV, that tend to cause gamma globulinemia. Obviously, we're going to test for those things anyway, but one additional reason to suspect them more highly. Okay, that was a really good discussion, Peter. Thank you for that. Travis, you want to give us the next aliquot of information?
You got it. So I will finish off with a good chunk of labs here, and that'll kind of take us towards the end. Okay, so and I can always add if I go too fast, I can add them on the board as well. So Bartonella Hensley and Bartonella quintana PCR was negative. Brucella IgM, IgG were negative. Coxiella IgM and IgG were negative. Leptospira IgM was negative. Blood smear for malaria was negative. EBV monospot was negative. EBV antibody panel, which includes VCA, or the viral capsid antigen, was IgG positive, IgM negative. EBV NA, or the EBV nuclear antigen 1, was IgG positive. And EBV EA, or the EBV early antigen, was negative. Epstein-Barr virus PCR was detected at 335 international units per ml. A MERS PCR panel was negative. It's Middle Eastern respiratory virus, or MERS. Toxoplasma gondii was PCR negative. And there's one lab test left off here that I'll just wait for the end.
Kevin, I don't know about you, but I think figuring out what to order is hard, but then figuring out once you get all of these tests back, some are positive, some are negative, some have numbers, some just say yes, no. That's really, really hard to do also. So I'm looking forward to tackling with this because I need to think through this a couple times. I think Before we jump in, just at the most simplistic level, do you have the sense of like what is a PCR test versus an antibody test? Like, what is the difference of those? Because I think that might be helpful for us tackling these test results.
Yeah, so for me, when I see a PCR test, that's more along the lines, not necessarily exclusively of an active or current infection, whereas the antibody tests more tell me the time course of either a chronic or a resolved infection. So when I see an IgM, it tells me that it's either an acute infection that's resolving or one that's, maybe recently resolved. And then the IgG tells me that it's a, previous infection that's generally resolved. Obviously, depending on the type of antibody that it's to. Like for example, with the labs we have here, the nuclear antigen tells me that I thought it was IgG positive. Is that correct? The nuclear antigen.
So the EBV antibody, the viral capsid antigen was IgG positive, but IgM negative.
Okay.
Is that what you're referring to?
Yeah, so I saw the nuclear antigen.
Okay, and the nuclear antigen was IgG positive, and the early antigen was negative.
Okay. Yep. Yeah, so that kind of tells me that this person had some infection at some point in the past with Epstein-Barr virus, which is not surprising since a good proportion of the population has been exposed to it at some point. But it tells me that it's resolved because you don't see the early antigen, and it's the IgG type antibody. The PCR is a little bit interesting for me because it kind of tells me that something's going on with the Epstein-Barr virus. I don't know, if that's a terribly high titer, but coupled with the atypical lymphocytes, it has me a little bit more concerned than it just being kind of an acute infection. It has me more thinking along the lines of, some type of malignancy, whether it's Burkitt lymphoma or some type of, B cell lymphoma. But yeah, that's kind of the way I break down the PCR and the antibodies is just, one kind of gives you a little bit more information of what's going on currently, and the antibodies give you kind of more information of what has gone on in the recent past or, the distant past.
Yeah, I love it. I'm going to let you keep going here, but yeah, basically at a simple level, you're telling us PCR. I mean, PCR means there's genetic material from that infection, right, in the body that we can actually pick up and amplify. IgM and IgG show we have made antibodies to those with either the acute or the convalescent phase being determined by the antibody type, as you said. That's awesome. So Kevin, do you want to just kind of tackle each of these tests and match it up to our differential and tell you if you think we can rule it out or in, or we're not quite sure?
Sure. So just going back to the blood cultures for a second, them being negative ×2 tells us a little bit, but it doesn't tell us the whole story. It depends on what they were looking for in the blood cultures. It depends on how they incubated them, things like that. So I don't take a ton of stock in it, but it does kind of help me rule out a lot of kind of the septic bacterial causes since the blood cultures are negative. And then the Bartonella, Hensley, Quintana, the PCR being negative, I think that kind of effectively rules out those as being the current source of infection. Same thing with the Brucella and Coxiella. The Leptospira, the IgM being negative, I think that helps kind of rule that out. And I'm pretty sure if it was Leptospira, he'd be a little bit more ill than he was currently presenting. The blood smear being negative for malaria, I don't put, again, a whole ton of confidence in that because it could be one of those situations where it's just kind of a latent phase where maybe you're not seeing it in the blood, but potentially they're laying dormant in the liver. But it is kind of reassuring that the blood smear is negative. I would expect with the fevers that you would see something on the blood smear. So I think that kind of really lowers that on my differential, although it doesn't totally eliminate it. And then, we come back to the EBV panel, and I think this is where we're really going to kind of figure out what's going on. The Epstein-Barr PCR, I know it's not a normal range. Doesn't seem particularly high, but coupled with the atypical lymphocytes, I think the top thing on my radar is going to be some type of Epstein-Barr related malignancy, whether it's Burkitt lymphoma, whether it's B-cell lymphoma. I also don't see an HIV panel on here, which I'm wondering, and Travis can tell us if they ran it or not, but obviously, if this patient has been immunosuppressed for any period of time, that can easily lead to an Epstein-Barr reactivation, which his presentation kind of fits more along the lines of a mononucleosis, being that acute, but it certainly could be, some type of malignancy. So those are going to be the top two things on my radar right now. And then the diffuse fatty infiltration of the liver and the enlarged spleen that we have on the abdomen and pelvis. The enlarged spleen kind of fits along with that mononucleosis picture, especially an Epstein-Barr driven mononucleosis. And with the enlarged liver, I think that kind of goes along with the fatty infiltration. And I think that probably accounts for a little bit of the AST and the ALT elevation that we see there.
Awesome, Kevin. Way to break down just a huge list of results. And I will emphasize a few things. Yeah, I think having just running this list here, I really like your point about blood cultures, just in terms of, if they're standard blood cultures, recognizing that some bacterial pathogens just won't grow under normal conditions. So I think that's important to know. In terms of the other diagnostics we've gotten, I think the Bartonella PCRs being negative are really helpful to lower that down quite a bit. The IgM and IgG negative tests for Brucella and Coxiella are helpful. The one thing to keep in mind with serologies, though, is where the patient is in their illness. This patient it looks like he's 8 days symptomatic, so he's fairly early, though late enough where we might be able to see some IgM production. I just mentioned that because we're going to have to sort of make a list of things we've ruled out, things we are not quite sure that we can confirm ruled out based on the testing, and things we haven't checked for yet. So I just want to make the point, sometimes when we get serologies, we actually check 2 sets of serologies for certain conditions a few weeks apart to see if we happen to catch someone too early in their illness for antibody production, that a few weeks later down the line, oh, do we suddenly have something positive that wasn't positive before? Or if we had a positive antibody, is the titer, the amount that's there, way, way higher a few weeks down the line? I mentioned that because the Brucella and the Coxiella for Q fever, I kind of maybe want to put in that category of, okay, probably less likely, but given that he's just 1 week into his symptoms of his illness, that is something where if we don't find an answer with some of our other tests we're still waiting on getting the results of, I might want to come back to that again and consider rechecking down the line. Same thing goes for the leptospirosis, although again, the fact that IgM is negative 8 days in, helpful. The malaria smear being negative, I think, makes me comfortable putting that in the category of less likely, as well as these other negative PCR tests here. Kevin, I'm with you. I think the EBV, my interpretation of the EBV data here is likely prior infection with the IgG, and with that low level PCR number, I will look forward to learning from the chat later, but to me, that number just seems so low to sort of implicate the cause of his acute infection. But we'll look forward to hearing from Peter or Zavin if they have other thoughts on that. It might suggest he's been infected before and just has some low level viremia with what's going on. And then finally, Kevin, you're on the nose of what we're missing here. We don't have our HIV yet. We haven't checked for CMV or toxo, some of those other mononucleosis syndromes. We haven't looked for any kind of rickettsial diseases at all, which again, we could not forget his Northern California exposure, where there could be rickettsial disease there. And then we haven't looked for TB at all. Again, it doesn't quite seem to fit, but splenomegaly and fevers absolutely could be from all of that granulomatous inflammation. And then finally, the leishmaniasis we've mentioned before hasn't been tested for yet. So this is a case where it's great to get negative results. Sometimes we have to interpret them with caution to know if they truly are negative, and then make sure we've got our checklist of what we haven't tested for. Sounds like we're going to get the answer soon. I don't know if Zavin or Peter, you guys have any other comments before we go forward, or have any teaching about the EBV beyond what Kevin has taken us through.
Peter, anything you want to share?
I think actually someone just mentioned it in the chat because it just popped up on my screen, but I would still want to see like a more typical hepatitis panel just to completely rule them out. I mean, the levels of the AST and ALT aren't quite what I would expect to be as far as, typical for a hepatitis, because usually they're breaking at least above like the 500s from what I see. But it doesn't mean that he couldn't have it. And then also, I think I agree with everything else that's been said, and also just double checking on the that protein gap, because I think it'd be worthwhile just to make sure we fully rule out any kind of potential for malignancy, just to see. Unless I missed that in the labs, I didn't think there was anything in there. And I also agree with that EBV interpretation. That's how it kind of struck me as well.
Totally with you. And I think in real life, a lot of those really common things like HIV and CMV and viral hepatitis and stuff are actually stuff that comes back the same day. So we're working a little bit backwards, where like we would have had this information already, right? So yeah, I don't have anything else to add. Travis, why don't you bring us home?
Yeah, you got it. And so true. I think one of the things that we always, go through in these cases, like which labs, in the ER, when I have students, we always have like, oh, let's get this and that. I'm like, well, that won't come back for a week. So I'm usually not the one ordering that, but very true on some of these. So I just had to keep the cliffhangers and the discussion going. So we have a hepatitis panel that was negative for A, B, C, and E. HIV panel was negative. And CMV IgG was positive. CMV IgM was positive, and CMV PCR detected 21,000 copies. I have just a few little clinical pearls that I could share, if that's okay. So for the case resolution, so this is a human DX case. And, I know all you guys have it. So there's always some great teaching clinical pearls on here. So the patient was diagnosed with CMV, infectious mononucleosis. Due to his persistent symptoms, he was started on Valgang cyclovir, 900 milligrams Q12. His fever is resolved within 48 hours, although this could have been the natural course of the infection. So in immunocompetent adults like this gentleman, CMV most commonly presents as a mononucleosis-like illness with the negative EBV testing. About 1/3 of patients with CMV mononucleosis have a rash, but appearance can be variable and can include a maculopapular, morbilliform, or scarlatiniform rash. In CMV mono, the majority of patients have an absolute lymphocytosis with greater than 50% mononuclear cells and more than 10% atypical lymphocytes, like we have in this case. Those lab features are also seen in other etiologies of infectious mono. In addition to EBV, CMV in the USA, mononucleosis-like syndrome can commonly be caused, just as you guys all mentioned, HIV, toxo, HHV6 and HHV7. In endemic areas, tick-borne diseases like human monocytic ehrlichiosis and human granulocytic anaplasmosis can also present with undifferentiated fever, atypical lymphocytosis, and splenomegaly. Treatment in immunocompetent host CMV mono is usually self-limited with complete recovery over days to weeks, and antiviral therapy is not usually indicated. Very rarely, seemingly immunocompetent patients can present with severe disease with multi-organ involvement, including GI, CNS, hematological disorders, presenting with hemolytic anemia and thrombocytopenia and pneumonitis. In cases like that, antiviral therapy with either Valgang cyclovir, ganciclovir, or foscarnet are indicated. And one last pearl, CMV mono cannot be reliably distinguished from EBV mono based on clinical features. However, some clues to CMV in adults include, and I think Anne Marie mentioned in the chat that pharyngitis tends to be mild or absent, and cervical lymphadenopathy and tonsillar exudates are less common with CMV than EBV. So great discussion. I mean, you guys were all over it, talking about all the high points. So I enjoyed listening to you guys break it down. So thank you very much.
Thank you, Travis. And Kevin and Peter, thanks so much for joining us to discuss. Steph is teaching Ruben over there how to exist, but maybe someday he'll learn about mono as well. Thanks everyone for joining. So Valeria, do you want to, or was it Sukriti with the teaching points? Please summarize for us and we'll end the session.
Thanks, Davin, Steph, Travis, Peter, and Kevin. So in breaking down this case, we first approached fever. And right off the bat, Peter taught us that we must consider how a risk factor helps prioritize our differential, but we must keep our differential broad and entertain the possibility of an unrelated diagnosis. When we thought about the risk factor that was the travel, Steph helped us think about how we could think about this in terms of what history could we ask the patient. So things to keep in mind is duration of travel, whether the patient was staying in an urban or a rural locale, any sick contacts, and was there any new sexual exposure. Zavin taught us that our first approach is to consider common non-localizing infections such as typhoid, viral fever, and brucellosis in a place like UAE. And then the next step is to review specific endemic infections, gather data, and then match our illness scripts. Some of the other risk factors present in this patient was the exposure to sheep and other zoonotic infections that were at play. So we thought about anthrax and Q fever. The fact that he lived in Northern California also raised our suspicion for a possible coccidioidomycosis or rickettsial infection. And finally, Kevin also taught us that risk factors are present in different flavors, and also the fact that he smoked and he was obese could also affect the course of the illness, while not directly affecting his syndrome. The next thing that we did was to layer on the time course, and the acute time course made us more suspicious of an infection versus autoimmune or a malignant process. There's a great schema on the CP Solvers website that you guys can check out. And Steph taught us how to organize an approach to infections. So consider all 4 buckets: bacteria, fungi, viruses, and parasites. And then the next step is to consider base rates. So always think of community acquired infections before you jump to more exotic ones. The second part of our discussion revolved around collecting clues, and we organized our problem representation as a syndrome causing fever in a returning traveler with splenomegaly and atypical lymphocytes. This essentially narrowed our differential to mononucleosis, either EBV or CMV. Acute HIV, also a possible toxoplasmosis or an infection with the Bordetella or Bartonella species. As we've learned in the CP solvers, we could break down the splenomegaly as water, cells, and molecules. And given that this patient had atypical lymphocytes, we were really focusing on the cells and what etiologies could cause the atypical lymphocytes. We broke down the elevated protein gap as polyclonal versus monoclonal, and this something I learned today was that chronic non-bacterial infections like HIV and hepatitis typically cause polyclonal. So don't make the mistake of thinking about acute and chronic infections. With regards to framing our hypothesis, we had this huge infectious panel that we had to break down. And so we asked 2 questions essentially. The first one was, which infections can we definitively rule out, keeping in mind that test characteristics So all the tests that were PCR tests have a high sensitivity. So those infections we could effectively rule out. We then thought about serology. So you again think of two things in this. One is where is the patient in his illness course? So think about positivity as well as titers. And then what type of antibodies are positive, whether it's an IgG, which would indicate a prior infection, or an IgM, indicating an acute infection. And finally, think about what have we not tested for that fits the clinical syndrome, and hopefully you solve the case like everyone here solved the case.
Thanks, Sukriti. That was awesome. Travis, what a great case to share with us from Human DX. And I'll close by saying, see, it wasn't the camel's fault after all. So easy to think about that poor camel, but probably some human who coughed on him. So with that, teaching points, have a great Wednesday afternoon, evening, morning, everyone. Great to see you. Bye.
Hi, everybody.